بسم الله الرحمن الرحيم. أعزائي طلبة السنة النهائية السنة السادسة في كلية الطب. النهاردة هنتكلم على approach to lymphadenopathy including the clinical examination of lymph nodes. Learning objective of these lectures will be knowing nodal distribution and anatomical drainage of lymph nodes, approach to patient with peripheral lymphadenopathy, differentiate between benign and malignant lymphadenopathy, lastly indication for nodal biopsy. We will start with brainstorming of a case which we will solve at the end of these lectures. It is a 41 years male, had a right-sided cervical lymphadenopathy since 1 week, no fever, chills or weight loss. He denies any sore throat, ear pain or dental problems. Clinically, we found a 1 centimeter anterior cervical firm, not tender, mobile mass. No others hidden neck masses, no skin lesions are evident, no systemic lymphadenopathy is found. The question is, how should you proceed with this patient? Final aspiration cytology, assurance as a location and duration typical for viral etiology, chest X-ray and CBC, or re-examine these gentlemen in 3 to 4 weeks. Lymph nodes. What's lymph nodes? Lymph nodes is a small encapsulated kidney-shaped organ. It lies along the lymph vessels. As we see from this photo, it is kidney-shaped with a hilum. It contains of cortex and a matrix inside histologically. The convex surface, including multiple afferent vessels, lymphatic vessels, come draining into this lymph node, and from the hilum it emerged 2 or 3 efferent lymphatics to the next lymph nodes. What's the function of the lymph nodes? It mainly infiltrate lymph on its way to the blood, get rid of any particles or antigen, and inside it the antigen activated lymphocytes happened. The main groups of lymph nodes in your body superficially is a cervical lymph node, axillary lymph nodes, inguinal lymph nodes. The supratrochlear lymph node is superficial, but it's mainly affected by medical causes of lymphadenopathy, not surgical causes. As the deep cervical lymph nodes, we are confronted with thoracic lymph node, which we call it mediastinal lymph nodes, abdominal lymph nodes, which is including peri-aortic lymph nodes, and pelvic cavity nodes. These are the main groups of lymph nodes, but it's not all the groups of lymph nodes. What's meant by lymphadenopathy? The definition is a change of a size, number, or consistency of a lymph nodes. Any change of size, number, or consistency of lymph nodes called lymphadenopathy. Mainly, lymphadenopathy is divided into generalized and localized lymphadenopathy. The generalized lymphadenopathy, it's written in the feet of this diagram, represent 1/4 of all causes of lymphadenopathy, generalized lymphadenopathy. But the localized lymphadenopathy, it shows the more common type of lymphadenopathy. It's about 75% of all causes of lymphadenopathy is localized. 55% is in hidden neck, and this gives you the importance of lymph node enlargement of cervical region. Next is the inguinal lymph node, consisted about 14%, axillary lymphadenopathy is 5%, and lastly is supraclavicular lymph node, only 1% of any causes of lymphadenopathy. What's the clinical pictures of lymphadenopathy? We first have to know if we are dealing with localized lymphadenopathy or generalized lymphadenopathy, and since when this lymph nodes is enlarged, any symptoms and signs of any dysfunction of the body of this patient has to be discussed in the history. Is it painful or not? Is it tenderness or not? This is very important in lymph node enlargement. Also, we have to check if there is a splenomegaly or hepatomegaly, as these organs is a part of reticuloendothelial system of lymphatics. Location is denoting the draining areas. As you see here, the axillary lymph node, for example, draining the arm, breast, thorax, neck. The inguinal lymph nodes draining lower extremity through the vertical part, and genitalia, buttocks, and abdominal wall below the umbilicus in the horizontal part. Supraclavicular lymph node is draining the mediastinum, lung, and the left one draining as well the abdomen. Here we couldn't see the cervical lymph node because the cervical lymph node is a complex one and it will be explained in separate slide. This photo shows you just an example of epitrochlear lymph node enlargement. Epitrochlear lymph node enlargement, which is usually not a surgical causes of enlargement. Usually it's a medical cause of enlargement of lymph node. As we said, cervical lymph nodes is important because 1/3 of all lymph node in your body lies in the neck. Although it is a narrow area, but it is condensed with lymph nodes. We have to divide this lymph node to make it easier to be explained and to be easier to be studied. We divide into superficial group or deep group, and each one of these will be subdivided into horizontal and vertical. What about the horizontal superficial group? We'll start with submental group underneath your chin, submandibular group under the mandible, then parotid and periauricular lymph node in front of your ears, post-auricular lymph nodes behind your ears, and lastly occipital lymph nodes. This is complete the circle of the horizontal superficial lymph nodes groups. The superficial vertical groups condensed in the vertical 3 lines along the anterior jugular vein, the midline in the front of the neck, along the external jugular vein in the lateral side of the neck, and in the posterior occipital area along the accessory nerve. What about the deep cervical lymph nodes? It's also subdivided into horizontal and vertical part. The horizontal, you will see it when you open a patient mouth. You will find a circle of lymphatic tissue guarding the entrance of the air and food of your body. It consists of 2 palatine tonsils on each side, 1 adenoids, which is a pharyngeal tonsil above, and the lingual condensed lymphatic tissue below. This is a ring of Waldeyer, or Waldeyer as he is a German. The deep vertical group is the main stem of the cervical lymph nodes. It slides along the internal jugular vein. And as the interjugular vein is vertical in position and the sternocleidomastoid is oblique on it, the lymph nodes present above and in front of the sternocleidomastoid called the upper deep cervical. Behind the sternocleidomastoid is the mid deep cervical, and little bit behind and behind the lower border of sternocleidomastoid is the lower deep cervical lymph node, which including also a part of it a supraclavicular lymph nodes. Another division of the cervical lymph nodes, which is mainly a surgical division, because this division is important for us as surgeons because it denoted each area draining which part, and if there is a malignancy in this part, this area particularly has to be removed precisely. Area 1 is the submandibular region draining the mouth, the nose, the sinuses, and the front of the face. Area 2 is the upper deep cervical part mainly, and draining the ear and part of the side of your head and neck. Area 3 is the mid-deep cervical lymph nodes. Area 4 is the lower deep cervical lymph node, and sometimes including supraclavicular as well. Area 5 is the posterior triangle and occipital lymph nodes. Area 6 is the anterior mid groups of lymph node in the neck, and it mainly drains the thyroid and larynx. You can remember these areas by the letter Z, 1, 2, 3, 4, 5 as Z, and separately you have number 6 group as it is draining the thyroid and axilla. thyroid and larynx. Sorry. Sometimes they added group 7, which is a suprasternal lymph nodes. But in some lectures, it's only the 6 groups which is mentioned. Axillary nodes. It will be explained in details with the breast, but here we have to mention that the area drained by the axilla is mainly the breast, but including also the arm, thorax, and neck. Sometimes the axillary lymph node enlarged due to Hodgkin lymphoma or non-Hodgkin lymphoma, and sometimes also it's enlarged due to medical non-surgical causes of lymphadenopathy, as in cat scratch disease. Inguinal lymphadenopathy is the third important group of lymph nodes in your body. It consists of a horizontal group underneath the inguinal ligament and vertical group along the terminal part of your long saphenous vein. It drains mainly the lower limb through the vertical group, external genitalia, anal canal, and lower abdominal wall and lower back through the horizontal group. In this photo, you will see a patient with bilateral inguinal lymphadenopathy. The main cause of enlarged inguinal lymph nodes is not a malignancy. It's usually non-specific, chronic non-specific infection from mild infection from your foot, which pass unnoticed, but your lymph node is reacting to it. But the chronic non-specific lymph node, it has its specific characters, which will be explained later. Some venereal disease also causes enlargement of inguinal lymph node, and its common cause. Left supraclavicular lymph nodes. It called a nodes of Virchow, as we will see later. It drains, if it drains an malignancy from the abdomen and GIT. What's the mechanism it drains malignancy from the abdomen? You know that the thoracic duct, which drains the lymphatics from the abdomen, is going up in the thorax and then turn to the left and terminate in the junction between the left subclavian and left innominate vein. If this termination is blocked by malignant cells, the malignant cells will retrograde, spread to the nearby lymph nodes, which is the left supraclavicular lymph node. If this happens, this is called Troisier sign. You have not to forget that the supraclavicular lymph node as well draining the mediastinum, breast, and lung, so it could be enlarged for a cancer lung or a cancer in the mediastinum. We finished with the importance of the site of the lymph node enlargement and which areas it drains. What about the consistency of the lymph node you are confronted with? Does it differ, and does this indicate something in the pathology? If your lymph node is stony hard, probably this metastatic from any other primary cancer, mainly epithelial cancer, carcinoma. If it is firm rubbery, usually this is a case of lymphoma. If the lymph node is soft, it's infection. Soft, either infection, acute lymphadenitis, or chronic lymphadenitis, depending about does it you feel it tender or not tender during examination. Shooty lymph nodes means it is separated from each others and not tender at all and firm inconsistently, and you can separate, counted it. This is a character of non-specific lymphadenitis, which is explained later. Fluctuating sensation means suppuration either in acute abscess or in cold abscess of chronic non-specific infection. Lastly, the matting lymph nodes together means it adherent to each other's. It's an indication that this is a chronic infection with fibrosis, and it is a characteristic of tuberculous lymphadenitis. We will see here some famous nodes by names and its draining area. First one, as we see in this diagram with the red spot, is jugular-digastric lymph nodes, which lies between the cross of the internal jugular vein and digastric muscles. It is a lymph node draining mainly the tonsils and pharynx. In some cases with chronic tonsillitis, this lymph node is enlarged either acute during the acute attack or chronically enlarged and fluctuating in its size and consistency in chronic frequent affection of the tonsils. Second one is Virchow lymph node, which is supraclavicular lymph node, and if it is left side supraclavicular lymph node, and if it is enlarged due to abdominal malignancy, we call it Troisier sign. Delphian nodes, which is nodes lie one node of the mid-deep cervical lymph nodes, and it is characterized by its draining from the thyroid and larger cancer. It enlarged usually in cancer thyroid, and it needs to be checked out, excised with the thyroid if the case is malignant. Node of Colloquet, it is part of the inguinal lymph nodes. It lies deep in the femoral ring. Sometimes if it's enlarged, you can feel it clinically. It is usually enlarged due to spread from malignancy from the pelvis, mainly the uterus and ovary. Examination of lymph nodes. Starting from the neck, the examination of the neck could be done from front or from behind. It's depending about the relaxation of your hand and wrist and comfortable you feel with feeling of the lump. But usually it is better to examine the neck from behind because your hand will be in the relaxed position more. You will palpate. Don't forget to inspect the neck first before putting your hand. See if there is a localized bulge or something, a localized pulsation. Ask the patient to swallow and see if this swelling is moved with deglutition or not. Specify the characters of this bulge, side, shape, size, and etc. Then you'll start your palpation by the flat of your fingers in systemic way to cover all the groups of lymph node, starting from submental until the occipital in transverse manner and in vertical manner in all three lines, posterior, mid, and anterior group. If you find a lump by flat of your fingers, you can use the tip of your fingers to identify the specific characters of these lumps. These figures show you how you palpate the deep cervical lymph nodes in the first one, supraclavicular lymph nodes palpation, occipital region palpation. You can notice here he's changed his position to front to make his hands more relaxed. In the lower row you find how to examine the axilla, epitrochlear lymph nodes, and lastly the inguinal lymph nodes. Differential diagnosis of lymphadenopathy. That say what looks like lymph node but it's not lymph nodes. First is a sebaceous cyst. It's characterized by its fixation to the skin with a punctum, which is obvious in this photo. Secondly, lipoma. This gentleman has a huge lipoma in his neck, but the characters of lipoma, which is soft, slippery edge, pseudo-fluctuation, and free lombile will be evident on examination. Goiter by itself could be differentiated from lymph nodes, but the goiter is mainly in the midline and it's move with deglutition. Organized hematoma with or without a history of trauma could differentiate between it and lymph nodes in some cases. Dermoid cyst, which is inclusion cyst during development. The most common one is external angular dermoid at the outer part of your eyebrow. Branchial cyst is a congenital cyst due to abnormality in fusions of branchial arches. It is usually characterized by its site, which is basognomonic. It is originating in the upper part of the anterior border of sternocleidomastoid, and usually it presented in adolescent age. Causes of localized lymphadenopathy. We divide generally into inflammatory causes or neoplastic causes. We will see it in details in this slide. We will make it collectively and we will describe each one in details after. Acute inflammation will present it with a patient complaining of pain, short duration swelling, which is red, hot, tender, and sometimes fluctuant. Chronic specific infection with long duration of enlargement of a lump fluctuating in size, sometimes with discharge and sinuses. Chronic non-specific lymphadenitis, usually in a young child in the posterior occipital region. Neoplasm will divide into either early lymphoma, as in this case, this lady has a localized lymph node, but it's firm consistency and not responding to conservative measures. It has to be considered as early lymphoma, or it is local metastatic from adenocarcinoma, as in this lady, which we'll discuss in details later. Commonest cause of localized lymphadenopathy, especially in the neck, is not malignancy, is not a specific infection. It's usually due to viral flu, common cold, or some antigen exposure from the usual life. What about non-specific chronic lymphadenitis? Sometimes a mother's come with a child 6 to 10 years old, fearing that this lump in the neck is something bad. But usually it is chronic non-specific lymphadenitis. What's the character of it? Usually in children, common in girls because they have long hairs. Common site is the cervical regions, followed by inguinal regions, as we said before. It's fluctuant in size. Sometimes the mothers can feel it, sometimes she couldn't find it. It is usually firm, painless, not tender, and shooty. You can count it easily. What about the management of this case? First, you have to assure the patient and his relatives that it is not something bad. Secondly, you have to give the child non-specific analgesic. Follow up after 2 weeks is very important to make sure that the swelling decreased in size, not persist. Clinical pictures of tuberculous lymphadenitis. Long history of painless swelling, fluctuating in size, commonly in deep cervical and posterior triangle area. Lymph node usually varying in size and shape and consistency, usually matted together, adherent together. Sometimes it's presented as a cold abscess. What's cold abscess? It's a presentation of a chronic infection with TB, where caseous necrosis of the lymph nodes, causing the lymph node to be changed into a space filled with caseous material like an abscess. But it is cold, not hot, it's not painful, and it's not tender. And this is a cold abscess of chronic lymphadenitis. Lastly, if the condition develops more, it can break down, causing chronic sinusitis, as in this case. But in present days, we couldn't see these pictures too much. Investigation of a case suspect that the patient has TB lymphadenitis. Tuberculin skin test is not helpful, but it's good negative if it's negative. Biopsy with culture in laboratory animals is good, but it take a long time. PCR, which is a checking of the antigen of the TB, is a standard of care now and is very accurate in most of the cases. Don't forget to do plain X-ray chest to see if this patient has also pulmonary TB, as in this picture. Also, CBC will show lymphocytosis. Treatment of TB cold abscess. Systemic antituberculous drugs has to be started and see if it is enough to deal with the case or not. If not, and the cold abscess persists, you can try aspiration with local injection of streptomycin. Needle entrance through a healthy, independent skin. You see here that he puts the needle from above, with cascade pathway in the subcutaneous and the skin, to prevent and try to prevent formation of a sinus or chronic sinuses. What about metastatic lymph node? It's very important entity to see if your localized lymphadenopathy is due to metastasis or not. Usually the history is short, with a rapid progressive swelling, painless. Sometimes the patient is complaining of symptoms or a sign of a primary lesions in the mouth or in its neck or in scalp. Usually the lymph node itself is hard, irregular, and fixed to the surrounding tissue. If you suspect metastasis in this lymph node, you have to search for primary in all its draining areas, and this is why it's important to understand the draining area of each group of lymph nodes. On the reverse, I like to repeat this frequently. If you are confronted with a lump and dealing with a lump in a limb or in the neck or in the scalp, you have to check the draining lymph node groups, is it enlarged or not, and vice versa. Sometimes we call occult primary when the presentation is with metastatic lymph node only, but searching of a body of the patient couldn't find any primary. The most common sites of occult primary tumors in the head and neck, larynx and pharynx, thyroid, posterior side of the tongue, and airway sinuses. In the limbs, you have to search for melanomas, especially in hidden site, between toes, for example. In the chest, bronchial carcinoma and esophageal carcinoma could be very small and not obvious, but the lymph node is enlarged as a first presentation. And in the abdomen, there is occult primary, sometimes in stomach, pancreas, kidneys, or prostate, and lastly in reproductive organs as testes and ovaries. Biopsies. If we have a lymph node and we want to know exactly what the pathology, we have to take a pathology, histopathological biopsy. The standard of care is excision biopsy. Excise at least 2 intact lymph nodes without crushing injury or damage of its capsule. Inguinal nodes are avoided as it often demonstrates active hyperplasia. The preferred site to have a lymph node biopsy is the supraclavicular lymph node, followed by cervical and axillary. Fine needle aspiration not recommended, has a very little rule. It cannot distinguish between the subtypes of lymphomas and other pathologies, so it is not the best to have a fine needle aspiration in lymph node biopsy enlargement cases. Let's go back to the case, our gentleman in the beginning of these lectures. Which answer is right? I think fine aspiration has no rules in lymphadenopathy. Assurance is not the age of chronic non-specific lymphadenitis. He is 41 years old. Chest X-ray and CBC will not be helpful because he is not suspicious to have TB from presentation, but this gentleman has to be re-examined in 3 to 4 weeks after mild conservative treatment for broad spectrum antibiotic and non-specific analgesic. If the condition developed to be persist or more enlargement of lymph nodes, you have to investigate this patient as a case of lymphoma or metastatic from unknown primary. Lastly, if you need some help, this site is very useful for training for clinical examination of a patient with a lump or in the neck or lymphadenopathy in the inguinal region. It's a very helpful site. You can watch it by yourself. Thank you very much. I hope all the best for all of you. Thank you.